Welcome everyone to today's webinar. I'm Laura Lubbers and I'm the Chief Scientific Officer of Cure Epilepsy. I want to thank you for joining us today on International Epilepsy Day. Recently, our webinar series addressed some of the factors that contribute to disparities in epilepsy care here in the United States. It reviewed some of the strategies that can address these disparities and improve treatment outcomes for patients. However, it's important to note that more than 65 million people around the world are affected by epilepsy, and its effects can be even more profound in underserved populations worldwide. Today's webinar is entitled International Disparities in Epilepsy, Social and Economic Effects of Epilepsy in Sub-Saharan Africa. This webinar is part of Cure Epilepsy's 2021 Leaders in Research webinar series, where we highlight some of the critical research that's being done on epilepsy. As an additional resource, today's webinar, as well as all other webinars, are recorded for later viewing on the Cure Epilepsy website. You can also download transcripts of all of our webinars for reading. For over 20 years, Cure Epilepsy has raised more than $70 million to fund epilepsy research that supports our mission, which is to find a cure for epilepsy by promoting and funding patient-focused research. Cure Epilepsy provides grants that support novel research projects and advance the search for cures and more effective treatments. In 2020, we launched our Cure Epilepsy Catalyst Award to help accelerate the basic research that we've traditionally funded into the next stage of development and prepare potential new treatments for clinical trials. Today's webinar will focus on the complex challenges to epilepsy care in sub-Saharan Africa at the community, clinician, and health facility levels. Epilepsy in sub-Saharan Africa is more common than in the United States, and seizure disorders in Africa are associated with a high risk of early death from seizure-related injuries and status epilepticus. In addition, the epilepsy treatment gap, meaning the number of people with a chronic active seizure disorder who are not on treatment, is 50 to more than 90% in most African communities. This webinar will also address potential interventions aimed at preventing some common causes of epilepsy in Africa, including prenatal brain injuries, the high incidence of automobile-related injuries due to poor transportation infrastructure, and cerebral malaria. Today's webinar is presented by Dr. Gretchen Burbeck. Dr. Burbeck is a professor of neurology and the research director and chair of the epilepsy division at the University of Rochester. Dr. Burbeck has served as a physician, medical educator, and researcher in sub-Saharan Africa since 1994. Her overarching professional goal is to understand common neurological disorders in the region. She also seeks to identify modifiable risk factors for these conditions and their secondary comorbidities so that feasible, affordable, evidence-based interventions aimed at preventing or reducing neurological injury can be evaluated and broadly implemented. Before Dr. Burbeck begins, I'd also like to take this opportunity to note that the first part of today's presentation was pre-recorded to ensure a stable internet connection, as Dr. Burbeck is coordinating this webinar as she travels to her research location in Africa. We will then be joining you live for the Q&A portion of the webinar. During the pre-recorded portion of the presentation, I encourage everyone to ask questions. You may submit your questions anytime during the presentation by typing them into the Q&A tab located at the bottom of your Zoom panel and then click send. I also want to thank those who submitted questions in advance of today's webinar. We will do our very best to get through as many questions as we can. We also want this webinar to be as interactive and informative as possible. However, to respect everyone's privacy, we ask that you make your questions general. So with that, I'd like to turn it over to Dr. Burbeck.
Thank you, Dr. Lubbers. And I'd just like to say, on such an auspicious day, it's a real honor to have an opportunity to speak with Cure Epilepsy on this webinar on a topic that is quite near and dear to my heart. Next slide, please. So just a brief overview of what I'll be discussing in the next 25 minutes. I'll go over a little bit about the epidemiology of epilepsy in sub-Saharan Africa. So how many people have it, what causes it. I'll discuss at some length the treatment gap, which is really quite horrifying in this part of the world, and then the actual burden of epilepsy in that region. Not just the number of people with the condition, but things such as premature death, the economic impact of epilepsy in Africa, and then a little bit about the pretty stunning social morbidity associated with the disorder. And then finally, we'll wrap up with a few thoughts about the way forward to try to decrease this burden of disease in such a resource-limited setting. Next slide, please. So, as we've probably all heard on numerous communications, 80% of the people with epilepsy who reside on our planet live in low-income countries. Now, there are disproportionate numbers of people living in those countries as well. So you could ask yourself, is that just sort of a, it makes sense there are more people there. But in fact, comparisons really suggest that the burden of epilepsy is much heavier in regions of the world, such as Africa. Direct comparisons are difficult. Challenges include things like age distribution adjustment. In Zambia, a third of the population is under 15 years of age. So when you start looking at epilepsy cases, how do you compare epilepsy cases in a population that's so very young with a population like the US, which is quite a bit older? Study design differences are challenging as well. One of the commonest ways to count epilepsy cases in a sub-Saharan African setting would be to do a door-to-door survey. Boy, can you imagine somebody going through a suburb trying to do a door-to-door survey, or an urban setting in the US? Very different. So the study designs are different. And then perhaps most importantly, the prevalence estimates, meaning the number of people with epilepsy captured at a particular time or in point or period in time, can be very different. And that may be different because if you have people with epilepsy dying at a more rapid rate than people without epilepsy, you actually may fail to capture them in a prevalence survey, and you can't capture them from an incident perspective because of the high mortality. So if mortality rates are disproportionately high among people with epilepsy in Africa, these prevalence estimates are probably a grossly low estimate of the number of cases because people simply die too quickly. Next slide. In this nice study that was published in Seizure a couple of years ago, they actually map out here the prevalence rates as well as the incidence rates when available. So prevalence is the number of cases at a period of time, incidence of the number of new cases. And you can see, for example, Tanzania is running at 10, a Cameroonian study at 58, Uganda at 13. Compare that, for instance, to the United Kingdom at 5. Now, these are just little points in time, but it certainly gives you a flavor that there's more disease in sub-Saharan Africa than in the wealthier West. Next. This perhaps more sophisticated study was completed based upon a very exhaustive review of published data, published in Lancet Neurology in 2017. If you have an interest in this, this is a very comprehensive review. And they looked at regions of the world, comparing door-to-door surveys and then cross-sectional surveys, which are probably a bit more similar to what we would be doing in the West. And again, the rates are substantially higher than we would expect in a place like the US or UK, being as high as 64 in Central Africa, 22 per 100,000, I might add, in West Africa. Next slide, please. In my own work some years ago with a colleague, we actually did a door-to-door survey in our rural catchment area of 65,000 people. And I should say it's important to understand what might prompt these surveys. So it's quite possible that they're not done in your average location. We actually did this door-to-door survey because we were very distressed that based upon the formal records of our catchment area of 65,000 people, there were only 32 people with epilepsy in the region. That number would be low for any place in the world. But we also knew that a third of the patients being admitted to our burns unit were coming in with burns that occurred as a result of seizures. And most of these people had chronic seizure disorders and weren't listed in our registry of 32. So we could appreciate a pretty severe disconnect between what must really be going on in the community and what the hospital recognized. That's why we did this door-to-door survey. We found a prevalence of 14.5, which actually ended up being more than 2,000 people in our catchment area, not 32. So these studies occur in a context that sometimes can't be appreciated just by the numbers. Next slide. So what about the causes of epilepsy? If epilepsy is so much more common in regions of Africa, why might that be? Next. Well, there's a number of reasons and pretty good data to support these. Poor antenatal services are very problematic. You saw my photo of the rural areas where I work in Zambia. People travel great distances to get antenatal services, and that's a big deterrent. Being away from home is often being away from farming and has a direct impact on the family's capacity to feed itself. So just accessing care can be quite difficult. Then the quality of care when it's accessed is quite suboptimal in many regions. So antenatal birth injuries related to hypoxic ischemic disease or related to abruptions, other things that in our setting in the West would never occur, quite common. You may not hear very much about it in the epilepsy world, but Africa is under a tsunami of hypertension and diabetes coming across the continent as Western diets arrive. And those premorbid conditions really contribute to a lot of cardiovascular disease. In addition, we still have quite a lot of rheumatic heart disease from infections in youth that aren't treated. And so that combination of hypertension, diabetes, and heart disease results in quite a lot of strokes. And of course, a certain proportion of people with strokes will go on to develop epilepsy. A traumatic brain injury is also quite common. Conflict in this region is well recognized. Next slide. But road conditions, much as this might look comical, are really tragic. Vehicles with no brakes, vehicles with no lights, overcrowded vehicles, roads that were designed with the assumption that there would be 10,000 cars, now there are 100,000 cars. And of course, the victims of these road traffic accidents are not just the individuals in the vehicle, but we see lots and lots of pedestrians involved, and survivors almost always have some level of head injury. And then, of course, there are infections. Infections have been my own interest for many years, the causes of epilepsy that are infectious in Africa. Next slide. So you saw in the previous slide neurocysticercosis, which I think most people are familiar with. But in fact, cerebral malaria is probably one of the commonest causes of epilepsy in Africa. This is severe malaria that comes to involve the brain and primarily involves children. So in an area where there's a lot of malaria, adults, by the time someone reaches adulthood, they have a fair amount of immunity, but children under 5 do not. And it's the commonest killer of children under 5 as well. In this setting, you have young children who are previously very healthy that suddenly become ill. They come ill with coma, seizures, and about a quarter of them will not survive. But studies that we've done out of Blantyre, and these have good corroborating data from Kenya, suggest that about 135,000 African children who survive cerebral malaria each year will go on to develop epilepsy within 2 years. Again, that's 135,000 children a year developing epilepsy in Africa as a result of malaria. So malaria, in addition to being a big killer of children, is also a big devastator in terms of causing epilepsy in this region. Next. We also believe systemic infections that have delayed treatments and result in very complicated febrile seizures are a problem as well. In rural Zambia, we did the CHIEFS study, that was the chikungunya epilepsy and febrile seizure study. We enrolled 214 children who'd come in with febrile seizures, and these were not brief febrile seizures. This was febrile status, very focal, complicated, difficult cases. And completing quarterly follow-ups over 3 years, 14% of these children developed epilepsy. None of these children had meningitis. We excluded those. So these are just children coming in with febrile seizures that are very complicated by the time they present, again delays in care. So just general better care for children might result in better outcomes in terms of less epilepsy cases in this part of the world. Next slide. Well, okay, those are the causes. What about the treatments? What are the treatment opportunities for people who are experiencing epilepsy in an African setting? Next slide. When we think about the treatment gap, and of course, as I think most people on this call are aware, that's the number of people who have epilepsy that warrants treatment that are not on treatment. That treatment gap, we'd like to have it be as small as possible. This is a compilation work put together by Dr. Anna Claire Meyer about a decade ago, and I'm sad to say I don't think the data has probably changed a great deal. You see here on the y-axis the treatment gap. So the broader, the bigger the bar, the greater the gap. And in fact, as you can see on the far left, where we show low-income places like Uganda, Zambia, Nigeria, that treatment gap is approaching or at 100%, meaning nobody with epilepsy is getting treatment. This treatment gap is huge, all above 80%, almost uniformly in these low-income settings. And again, in the African settings, approaching 100%. In our own study in Zambia, more than 95% of people were not receiving treatment when they were identified. Another notable thing is that it seems to be worse, perhaps among people in rural settings. Not a surprise given the distances that people have to travel for care and given the low resources that are usually available at some of these very rudimentary rural clinics. Next slide. I think bringing this forward to today, there's some very novel and important work being done by Dr. Edwin Trevathan at Vanderbilt, who is conducting a randomized controlled trial with a number of very talented colleagues in northern Nigeria. And in trying to overcome this treatment gap, they're actually doing an RCT that's randomizing children to usual care, usual level physician care versus community health worker care that's being guided by very carefully developed algorithms. These children are being actively sought out in clinics when they're coming for other reasons. And this study really will help us understand if we can shift the care away from physicians to community health workers and therefore maybe narrow that treatment gap. This study is amazing, and its rate of enrollment has been about triple what they expected, very rapidly enrolling. They had already estimated that in Nigeria today, the treatment gap in northern Nigeria would be about 65%. They're enrolling so rapidly because it's over 90%. Over 90%. So even these kind of dire estimates of over 65% were very low estimates, it turns out, based on what's really found when you go into the clinics and start identifying active cases of epilepsy that aren't being treated. Next slide. So the treatment gap is pretty dire. What does this mean in terms of perhaps mortality rate in this population? Next slide. What about deaths? Well, we don't very often do population-based studies looking for deaths among people with epilepsy. I mean, the SUDEP world is trying very hard. That's difficult study design. But virtually any study that's following people forward in time who have epilepsy in the African setting will report multiple, numerous early deaths. I can tell you the Bridge study is finding these. The epilepsy study I cited from Malawi, the work we did with febrile seizures in Zambia, people with epilepsy dying often of status epilepticus. And the status epilepticus deaths are very tragic because they're often occurring in the setting of sudden drug shortages. The most common medication still used in most regions of Africa to treat epilepsy is phenobarbital. And as some of you may know, that is not a drug you can stop suddenly. So people are being managed with a drug that really, if you were going to discontinue it, you would have to wean it very slowly to avoid rebound seizures. The drug suddenly becomes available, and then you just have a rash of status cases, people often dying in status epilepticus at home. We also see lots of deaths amongst people with epilepsy related to burns and drowning. Keeping in mind, particularly in the rural areas, people spend a great deal of time around open fires. This is how they heat their homes. This is how they cook. So somebody with epilepsy who has a seizure is quite at risk to coming in contact with open flame. Similarly, collecting water from open bodies of water, rivers, streams, not an uncommon means of acquiring water. And if you have uncontrolled seizures, the risk of seizing and then falling into a body of water is quite high. I'll talk about it a bit more, but the fear of helping somebody who's in the midst of a seizure-related accident because of contagion fears may actually worsen these early death rates as well. Now, this is to some extent anecdotal data. What do we know from a population basis? Very little. But there's excellent data from rural China that came out of the World Health Organization epilepsy treatment demonstration project that showed even after they instituted care very broadly for epilepsy in rural China, prime age adults died at about 4 times the rate of comparable aged adults in their community. Now, these were individuals who actually had access to treatment, so they weren't status epilepticus related deaths. Most of these were accidental deaths, again, related to burns, drownings, and falls. We could step back, and then when you think about a treatment gap approaching 100% and what we know about the risks for sudden unexplained death with epilepsy, you might be very concerned about SUDEP rates in Africa. And I'm sorry to say we have no data on that other than to suspect that these must be quite high, and we just don't have the information. Next slide. Well, stepping back from deaths, what about cost? What is the cost of epilepsy to this environment? Next slide. In trying to look at costs, you can look at costs from various perspectives. You can look at it from a payer perspective in the US health system. You can look at it from what the individual or their family is paying. There's one very excellent study, and it's the only one I could find. This is a study out of the Congo. And this study involved asking people who had a family member with epilepsy about the costs that they incurred throughout the course of the year related to seeking epilepsy care. Now, in the Congo, the average family spent $241 in a year. That may not sound like very much, but that was roughly half the household's family income. So half of the family income in these really poverty-stricken areas being spent towards direct costs of epilepsy. Direct costs are listed in this slide as well. You'll see that about 20% of that went towards medications, a small percentage to medical consultations and hospitalizations, but the vast majority actually went towards seeking traditional medicine. Next slide. We really cannot underestimate the role of the traditional healer in epilepsy care in Africa, perhaps more so in the rural than the urban settings. There is historically quite a lot of conflict at times between healers and Western medicine. But as you see from this slide, people spend most of their money on the healers, and the healers are much more accessible than physicians. So I'm a proponent that we need to recognize this cadre of people as potential partners, because it's definitely where a lot of the investment goes. Next slide. Well, that's from the family's perspective. What about from the health sector perspective? My colleagues and I at the University Teaching Hospital in Zambia, collaborating with the Ministry of Health, actually did a costing study, and we used actual costs, and we were able to pull data related to a vaccination program in country. So these were very solid costs in terms of what does it cost to have a health center and to pay a healthcare worker, and for that health center to keep the lights on and buy drugs. And we really had a model in which people who had seizure disorders came, most of them could be taken care of at the primary level. Some would be referred to the secondary, and then about 1 in 10 would require tertiary care related to either seizure severity or other concerning aspects of their seizure disorder. We costed all of this out, and I do mean it was a very comprehensive costing study. And remarkably, for the person who needed epilepsy care that could be cared for at the primary healthcare level, it was less than $14 a year, going only as high as $61 if they had to go all the way to the teaching hospital and have a fairly extensive workup. So really, by local estimates and local costing, epilepsy care is very affordable in this setting for a chronic disorder. Next slide, please. I would like to point out that talking about costs incurred, such as occurred in the Congolese study, I think by anybody's perspective is probably a pretty poor measure. Households are simply too poor in this environment to purchase all the care that would be needed, and that's assuming the care might actually be available locally. So looking at it from the households purchasing, cost incurred really just tells you the burden. It doesn't tell you whether adequate care is being accessed. I'd also caution us to think about costs incurred from a healthcare perspective if we don't know how it's structured and how comprehensive the delivery is. The sad reality is providing no care is cost-free to the health sector, and all too often that's what's happening in these environments. Perhaps one of the saddest realities is that the World Bank ranks epilepsy among the top 5 chronic conditions that are the most cost-effective to treat. You saw the data from Zambia. This is not an expensive disorder to treat for the most part. And yet the treatment gap, as we saw, remains extremely high. Extremely high. Now, why might that be? I believe there are 2 core issues. And one, next slide, please, is related to the lack of grassroots expertise and advocacy on the ground in Africa. I'd like to talk about that first and address stigma second. Next slide, please. This is a quote that preceded a book coming out from the Institute of Medicine in 2002, noting that health policy on brain disorders has long been limited by the misperception that neurological illnesses are a problem in the developed, but not the developing world. And they go on to point out that this is clearly erroneous, since most people with epilepsy actually live in developing countries. I think that this was terribly true in 2002. I think things are moving forward, but we still have an environment that really lacks sufficient expertise to not only care for epilepsy, but also to advocate for it. Next slide, please. Now, this is a slide some of you may have seen before. It depicts, from a color perspective, the number of neurologists per 100,000 in the population. And you'll see the purple regions are contained in Africa. If you see a white region, there wasn't even anyone knowledgeable enough about the presence of neurologic expertise in the country at the Ministry of Health to complete the survey. You'll see the little blob of purple in the very middle of sub-Saharan Africa, and that would be Zambia and Malawi. I was the person that completed this survey 15 years ago, and you'll see it was less than 0.1 person per 100,000. Even when 5 colleagues joined me, because of the numbers of people in the country, we would have remained at this 0.1. Now, that's changed very recently for Zambia, but as a general rule, there really are vanishingly few neurologists in this part of the world. Next slide, please. But the problem isn't just an absence of neurologists. This depicts, by territorial size, the proportion of the gross domestic product for purchasing power. So you can see how poor these regions are. And I can tell you that this same diagram applies perfectly for the number of physicians. So we have a problem with not neurologists, but we also have a problem with no physicians. Most care is being delivered by clinical officers who get 2 years of training after high school, and without active intervention by groups such as Cure Epilepsy and individuals such as myself, epilepsy often doesn't make it onto the training curriculum for these non-physician healthcare workers. Next slide, please. So what about stigma? What role does stigma play in all of this? Next slide. When we think about healthcare delivery and health sector, I think it's very important to step back from our usual thoughts about stigma at the individual level and think about structural stigma. Structural stigma is sort of depicted here in the middle of the diagram. And the structural stigma is the social stigma that's perpetuated on sort of a public basis, that there are different treatments from first-line providers, from healthcare providers, customer service, but there's also differences in human resources, et cetera. And I would really like to make the argument that the overall stigma associated with something such as epilepsy doesn't just impact the individual, but it impacts the investments that a country makes in the care, that a country makes in the training of people who could take care of epilepsy, in the provision of services such as imaging, EEG services, and very critically, basic drug services. In most countries, anti-seizure medications such as phenobarbital and carbamazepine are absolutely on the essentials drugs list. But if you look at how often those essential drugs are out of stock compared to other essential drugs, it's disproportionately high. So structural stigma absolutely impacts the resource allocation. Then, of course, social stigma, as we all know, plays a huge role, and I believe probably a disproportionately heavy burden on people in Africa. This was a quote from a focus group discussion we held once, where a woman was describing when she'd had her second seizure and it was clear to the family she had epilepsy, that her uncle, and in this culture, her uncle should be her greatest protector, had said to her, if someone is bewitching you, better they should just kill you. And that attitude is all too common and faced by people who suffer from seizure disorders in this part of the world. Next slide, please. To sort of pull together this link between individual burdens of stigma and how that translates when it meets with some of the structural burdens, we've sort of developed this model that we call the accumulated burdens of stigma, or the stigma stairs. And the key features about this, as you see, someone has a seizure disorder, they're losing illness, they're losing time at work to illness, they're now incurring care costs. But as you go down, you realize that the cost of the care is one issue, but the quality of care for stigmatized disorders such as epilepsy is proportionately poorer than the quality of care for other conditions that aren't stigmatized in that setting. So even if they can access care, the care is poorer. We also know that the infrastructure that's available in the household for people with epilepsy gets diminished as they become less and less economically stable, so that we see people with epilepsy in Zambia are actually more likely to live in households without running water, to live in households that use open fires as opposed to stoves for their heating, so that their risk is disproportionately high as well. So you have this kind of steady decline that ultimately results in entire households suffering from poverty, and sadly, abandonment of the person who has the seizure disorder is all too common. Next slide, please. So given that sort of bleak reality, what are the next steps? Next slide. I think we can think about them in sort of 3 different categories. And I think that Cure Epilepsy I'm a big fan because it addresses what I would consider the root causes of could we prevent epilepsy to begin with. Now, in places such as Africa, many of the measures to reduce epilepsy would really be outside of the realm of neurologists, but would be more in terms of medical and social infrastructure, better antenatal care, more available antenatal care, better vaccine programs. Many of those complicated febrile seizures occur in the setting of vaccine preventable diseases. Improving road conditions, let's have lights and brakes on the vehicles that are on the roads. And then of course, more appropriate and rapid management of febrile seizures in children. I think we also need to think about neuroprotective interventions. Much of my own work now is aimed at looking at neuroprotective interventions for children with cerebral malaria. For a child to survive cerebral malaria, they had to seek medical care. So we have them in our clutches. Can we do anything besides treat the malaria itself to try to protect the brain, to try to prevent that 185,000 children who we can expect to develop epilepsy as a result of cerebral malaria? Can we prevent some of those? And we have now our 3rd clinical trial, this one looking at more adequate temperature control, preventing hyperpyrexia in this population. So really addressing the root causes is needed. To decrease the disparities, we also desperately need to narrow the treatment gap. Next slide. Now, of course, narrowing the treatment gap means more advocacy. And I think it's really important, and a tribute to probably many of the people on this call, to just recognize what's facing people who are epilepsy advocates. There is so much that needs to be done in so many areas of the world and our own lives calling for advocacy. So that's not a trivial ask, but narrowing the treatment gap really is going to happen primarily through advocacy and local experts. And then finally, stigma reduction interventions are really going to have to play a key role in these. I think, some years ago, we envisioned stigma reduction interventions as being sort of mass social marketing campaigns. And over time, I think we've come to appreciate that those are probably not effective and certainly not sustainable. My own work has involved looking at interventions that are focused very much on epilepsy and looking at interventions that are school-based and health sector-based. And I think, as we mature as a discipline and a stigma reductions in discipline, I'm really coming to believe that we need to work with unified theories about how to form interventions. What do I mean by unified theories? Those basic human tendencies to stigmatize epilepsy are the same tendencies that stigmatize leprosy, that stigmatize any number of health conditions. And it should be feasible to develop stigma reduction interventions that address a number of conditions at one time and would be more sustainable, would have more economic and political support. And perhaps that's the way forward when we think about stigma reduction interventions. I think that's probably the next generation coming. Next slide, please. So with that, I'd like to thank you for allowing me to share part of this special day with you. This is my epilepsy care team in rural Zambia in 2019, all of whom were quite heartbroken in 2020 when we couldn't have our community-based activities. Again, we're in the same sad COVID situation that we can't do that this year. So we're hoping very much 2022 will look more like 2019. Thank you for your attention.
Thank you, Dr. Burback. Thank you so much for such an impactful and haunting presentation. Clearly, many populations around the world are suffering and need support. Thank you again, Dr. Burback. We are joining her live now as she is en route to her research site in Africa on this very prominent day of International Epilepsy Awareness Day. So again, I want to thank you for making the time to give us that presentation, and also having you here to address questions. We invite our audience members to pose questions in the Q&A tab located at the bottom of your Zoom panel and clicking send. I know we already have a couple that have come in, and I also want to apologize for the earlier issues that we had with audio, but those seem to be solved. So let's go on to the first questions that we have. This question comes in, is about cerebral malaria. Is it more likely to cause seizures than neurocysticercosis?
Good question. I don't know that there's been a head-to-head study. And neurocysticercosis in many ways is more heterogeneous, so people can have lesions in different places, and the risk of subsequent epilepsy is probably based upon the location of the parasitic lesion. And so I think it would be hard to do a head-to-head study. And I think the location may matter as well. So obviously there's limited cerebral malaria in, say, some areas of Latin America that have quite a lot of cysticercosis. We actually do have plenty of cysticercosis in Africa as well. So I think it's probably just safe to say both are really contributing to the burden anytime you get into low resource settings.
Okay, thank you. Here's another question related to stigma. Why do you believe that stigma reduction interventions cannot be streamlined? Can you give examples of what hasn't worked in the past?
So the mass social marketing campaigns that were looked at, if you examine the outcomes of that, not what they did, but rigorous assessments evaluating whether they actually impacted stigmatizing attitudes. First of all, they weren't terribly well studied. And when they were looked at, usually the benefits were very short-lived. And those are very expensive things to do, and so they're not really very sustainable. My own group had looked at focused interventions in terms of, it was an epilepsy focus, it was epilepsy stigma reduction, but we identified power groups. So we worked very closely with people with epilepsy and came to recognize that rather than trying to decrease stigmatizing attitudes in the general population, we might benefit the lives of people with epilepsy more if we targeted individual groups of people who have a big impact on the lives of people with epilepsy. And we decided or determined that that would include people like teachers, clerics, healthcare workers, police officers, because in areas where there's no 911, if someone has a public seizure, the police officer may be the person coming to the scene, and employers. So we did interventions with those groups, and some interventions were successful, some were not. Some are even being scaled up. But again, the cost of these interventions and the cost of sustaining them really, really quite high. So if we're trying to think about what could be sustainable, if we could partner with other common stigmatizing conditions, the models of the stigma, the driving forces of the stigma being shared, and work with those conditions to do sort of broad interventions, I think the sustainability would be more likely. So yes, you can do focused interventions that are effective, but the question is sustainability and scalability. So to do them in one country really isn't enough. We want to do them everywhere. If I can provide this after the talk, but we did an article, there was a whole series from the Fogarty International Center on stigma, and this was published in Nature. And we really try to make the argument about what these would look like, these sort of broader stigma reduction interventions, that epilepsy could be one of the conditions that's looked at. And I do think if such interventions were sort of developed, say by the World Health Organization or the World Bank, and scaled up, those interventions would almost always include epilepsy amongst the conditions of interest, because it is very well recognized, I think, even outside of the epilepsy world, that when you think about health-related stigmatizing conditions, epilepsy is unfortunately at the top of the pile.
Great, well, thank you. Actually, on a related note, one of our audience members noted that there's an advocate's toolkit for making epilepsy a priority in Africa, and that can be found at www.epilepsyafrica.org. That's a great resource. And it sounds like we've got other resources that maybe we can gather and share with this audience. So another question Can you tell us a bit more about the traditional healing methods that are used and if any of these have been researched?
I have to say we've been very fortunate where I work in that we have developed, I think, a very effective partnership with our healers in the rural areas. And one of the things we discovered, it was actually in the setting of the Chiefs study, that was the febrile seizure study, which was requiring a cohort, a group of children that we would follow through home visits over several months. It was actually 3 years follow-up. And in trying to determine what would perhaps undermine those follow-ups, it was pointed out to us that if the traditional healers in the village didn't want children to continue to be in our study, they simply would pull out or be unavailable. So that was our original motivating factor, to bring in the traditional healers and speak to them about what we wanted to do and take advantage of that situation to talk to them about how they conceptualize seizure disorders and epilepsy, et cetera. And it ended up being a very positive foundational way to work with this group. And the way they described their understanding, and again, this is one region of Africa, so I cannot claim that this is generalized. Most of these rural traditional healers were from the communities. They had had some life event that had led them to be chosen to be a healer or believed to be a healer. And they have a very strong bond to their community. And I would say that they have a very strong therapeutic relationship with their population. That may be very different than some of the real scoundrels that kind of come through to make a bunch of money and leave. With that group of individuals, they really viewed, a seizure as a problem. They would intervene and the seizure would stop, as seizures usually do. And then some people would go on to have more seizures. So we would call those persons who now have epilepsy. And those patients they really didn't want to take care of because they didn't think they could help them. So what they viewed their role as was to take care of acute symptomatic seizures, which are usually brief and usually go away. So they were usually successful. And then when people developed chronic seizure disorders, they really didn't think that they could help them. And they, in fact, once the therapeutic door was open, they became very happy to refer those patients to us. So for the group that I've worked with, they actually don't believe that they're particularly effective at taking care of epilepsy. We do see them try, and many of them will tell you that trying to refer patients to health centers and hospitals are difficult because of the cost of the patients. And because often they will get to a health center and find there are no drugs anyway, so they've traveled all that way. The healers take excellent case history. So I'll often see a patient come who has, localization related epilepsy with sort of focal onset in one limb. That limb will already have tattooing or scarification. The healer has actually obtained the history. They give sometimes rather magical explanations that make sense to patients. So they might, if a patient has sort of an aura that is a rotten egg smell, they will decide that the cause of the seizures was witchcraft and that eggs were used in the magic. So there's a lot of reasons why their explanations and their management are sort of contextually very valid to patients. What I found most reassuring is that when I've worked with healers closely, most of them are very happy to refer chronic seizure disorders to us because they feel like their intervention is with the acute symptomatic seizure, which again is usually brief, is usually going to resolve, and many of those people won't go on to have a second seizure, or at least won't have one for some time. There are some healers that have particular herbs that they use, and we have seen situations usually in families that already have a family member with epilepsy and they have some traditional herbal teas in the household that are being given to that individual, where somebody with an acute symptomatic seizure will receive those. That can be problematic if sort of a hot tea is orally administered to some child in the midst of a febrile seizure, because then you have oral burns, aspiration pneumonia, et cetera. So for those sort of mismanagement, which I might say is actually the family taking a therapy for somebody else and administering it to the child without the healer's input, we have tried to do some public education about that to decrease the oral injuries and the aspirations that we've occasionally seen. But in general, in the rural healers in Zambia, what I found is once the therapeutic door is open, they will continue in the community to manage acute symptomatic seizures that aren't epilepsy, but refer epilepsy quite happily for care to the hospital.
Fascinating, fascinating interactions. Along those same lines, do religious leaders, can they decrease stigma and reduce that evil spirit etiology? Is that something they think about?
Yeah, so it's interesting. We did some early work trying to look at what the drivers of stigmatizing attitudes were in different important groups of people, power entities. And you heard me say that clerics are power entities, teachers are power entities. Each of the power entities we looked at, and we looked at teachers, police officers, clerics, and healthcare workers, each of those groups had different factors driving stigmatizing attitudes. So you've asked about clerics. So the clerics driver was whether or not they recognized epilepsy to be a stigmatizing condition. I'm sorry, to be a biomedical condition. So for healers who recognized that epilepsy was a brain disorder, it's like having TB or a broken leg, you need to take this to the hospital. For healers who recognized epilepsy as a brain disorder and not being bewitched and not being possessed, those healers actually had pretty good attitudes. They were not stigmatizers. So it was the clerics who were unaware of the biomedical basis of epilepsy who were stigmatizing. So it would seem that the ideal intervention would be to improve their knowledge. Now, that is one of the lines of investigation and intervention we did. So we did a series of intervention programs with clerics in a large swath of Zambia, and we were able to improve knowledge, and yet we didn't improve attitudes, and we didn't change how they were handling people with seizure disorders in their congregations. So then we went back to the drawing board and spoke to them and kind of in structured interviews and in-depth interviews to understand this better. And we'd failed mostly because they felt like they had to respond to seizure disorders in the way that their congregation expected and not necessarily congruent with their new knowledge. So that is a group we actually failed miserably with. Let me give you the success story since we've been talking about stigma reduction. So we were able to improve clerics' knowledge, but we could not change their behavior. They felt compelled to behave in a certain way based on congregational expectations. On the other hand, for teachers, we found that one of the primary driver was teachers are educated. They knew that seizures were a biomedical disorder. Whether or not they stigmatized, and I should say they stigmatized much less than the clerics, but their stigmatizing attitudes in terms of throwing kids out of the classroom, not wanting them in the classroom, thinking that they were not capable of some of the work, was really driven by whether they had any personal proximity to somebody with epilepsy. So did they have a friend or a neighbor with epilepsy? And if they did, then they were much more accepting of the condition. So our intervention with teachers was an educational program that took place over some days in like a seminar center where people were attending the seminars full time and eating communally and pre-COVID, eating communally and staying in accommodations next to each other and coming to know each other. And the instructors were people with epilepsy. The teachers found this out at the end of the intervention. So much as the intervention looked like an educational intervention, it was actually a personal proximity intervention. And that was roaringly successful in terms of not only changing teachers' attitudes and changing what they were doing, but actually also there was a knockoff effect with other teachers in their schools sort of changing attitudes over time as well, based upon interactions and education from that other teacher. So we failed miserably with clerics, I'm afraid, but we did have more luck with some groups such as teachers, healthcare workers, and police officers.
Great. Thank you for that really well-rounded answer. Here's a question. There's a couple questions along this line. What are the best ways for nonprofit organizations outside of Africa to support African organizations to narrow treatment gaps? And what areas are most helpful to approach first? Is it diagnostics, medication, advocacy?
Yeah, so I think here your local partners have to really inform you because it's really the situation on the ground, and it can be very different from country to country. It can even be very different from regions within the same country. And coming in from the outside, I don't think that we can really hope to understand what that is. I think that sometimes we come in with like a list of what we think people could need, and the more open we can be to really allowing the true needs to come forward from the community that's advocating on the ground, the better. Sometimes the asks, the things they may need might seem very unusual, but if you get the full details of what they're dealing with, it'll be clear. So I really think in these situations, local partners have to guide us because you just can't know from the outside.
Right, right. Okay, there was another follow-up question around, is there a line in Western medicine that people need to be aware of? Do we need to be more accepting and understanding of the traditional healing? Can we be wrong in our Western approaches or our big brother mindset?
Yeah, I think we have to at least be open to what the healers bring. And I think I've had a different experience than many people because of my sort of home base and work really originating in rural areas. So I really believe in the rural areas, the vast majority of healers who come there from the community, they originate there, they live there, and they're really very much view themselves as being responsible for trying to improve the health of their community. They often get very little in terms of personal income or gain, but they get a lot of status in their community. I've learned over time, most of those people have all of the best intentions. And I don't think I'm incorrect in that. On the other side, in the urban settings, I've seen plenty of charlatans coming through, and they'll whip into a city and they'll set up a clinic, and they'll appear from nowhere. They'll make outlandish promises. They'll charge huge amounts of money, and as soon as they make enough trouble for themselves, they sort of disappear quietly overnight with everything that they've made. I think we have to just be open-minded about who we're dealing with. I'd be very careful about sort of painting any group of people that are claiming at least to be trying to help individuals with seizure disorders as being bad just because of sort of a label they have. I think it's healthy to have some skepticism and to learn more. I wouldn't recommend sort of suddenly trying to support, unknown groups that are providing traditional medicines. But, there's a lot to be said for the therapeutic benefit to the family. Let's say somebody has their first seizure. It's a brief, unprovoked seizure. They may well go on to develop epilepsy. This is an intensely traumatic event for anybody, anywhere, first seizure, right? It means a lot to that patient that their family seeks care for them. And it doesn't matter that care may be garnered from the traditional healer in the community as opposed to a primary care clinic 12 miles away that they may not even know the nurse or clinical officer there. There's a lot of importance in the family unit and just people's responses to such an acute traumatic event of just a simple care-seeking process. And having healers in the community makes that possible. So I think we have to be open-minded and sort of willing to learn a bit more about what an individual is actually doing. What are their motivations for being in that community? Before we sort of decide that they're either all good or all bad.
Great, thank you. Very complicated community there. Here's another question. Is there a difference for children or adults with the first onset seizure? Is one or the other more likely to be referred for care?
It depends. So we have some data, sadly, to suggest that females in general are less likely to be sent for care in the African setting. And I think actually, sadly, they're seeing this in the Nigerian study that I cited as well. So that, sort of your value in the community, your value within your family probably determines how hard or how many resources are going to be expended to get care for you. And so if you are a prime age adult male, you're going to do a lot better in terms of resource seeking and the family investing in that than sort of, say, a young female. So yeah, it goes along power differential. The family wealth itself obviously makes a difference, but if you control for that, less valued individuals. And this becomes problematic if you think about somebody, let's say somebody with comorbid cerebral palsy or some comorbid condition that may be playing a role in their seizure disorder. Somebody who's disabled may be very much devalued by their community, and so may be very unlikely to have care sought for them because that requires resources that even within the family, nobody wants to invest. So yeah, unfortunately, there's differential care access even at the family level.
Right. Okay, thank you. Well, in our last bit of time for questions, what can people watching this webinar do? How can they support the cause? And in fact, one person has offered to, was interested in learning more about how to join research efforts in even your group, which is wonderful. You've clearly inspired people.
So I think, you know, there are groups like Cure Epilepsy, right? I mean, there you go. There are organizations that are already partnering with local organizations in communities doing important work. I think your best bet is to identify groups whose values and approach kind of resonate with yourself, because the more what they're doing sort of seems in line with how you feel about the condition and what the priorities should be, I think the more positive feedback that you're going to feel in your engagement. And then think about what you do. I mean, I see some people on the line here, and there are EEG technicians and people with those skills who sort of volunteer. There are people who give money. There are people who give support to educational activities that are ongoing to try to build local expertise. I think there's a lot of opportunities out there if you tap into everything that groups like Cure Epilepsy and ILAE and the World Federation. If you have a particular location in the world that you have some connection to, you might make some inquiries and say, what's going on in your community for epilepsy care? And you may be astonished to find that there's a small group there, you know, some grassroots group trying to advocate for, do something, and then you can do something more personal. We've done things for Christmas gifts just within my university where people can gift a goat. Now I know that's a thing that some of the bigger organizations do, but we've been able to do it on a small basis, and yet it has a big impact locally because of the revenues that then support some of our patients who are really on the most dire end of poverty and really can't afford medicine. So I think you have to kind of look for what works for you, but I think even a brief intranet search and you will find lots of opportunities to get involved. And then I would just look hard for the ones that resonate most with you so that you can have, you know, maximal enthusiasm for following through and engaging.
Great, great. Thank you so much. Thank you so much for such an inspirational and thought-provoking seminar. And I want to thank our audience for such great questions and engagement. It's clearly inspired a lot of people. I also want to let you know that we're interested in learning more about your interests in webinar topics. So if you have an idea for a future webinar, please do let us know at Cure Epilepsy or at research@cureepilepsy.org. And also please stay tuned for an announcement for our next webinar that should be coming out shortly. So again, Dr. Berbick, thank you very much. Very safe travels to you as you head off to Africa, and best of luck with your work.
My pleasure. Thank you, everyone.